Today we have Dr. Carla Danelli from TTUHSC Surgery to our special echo program. And she presents today on the applications of telehealth as they pertain to the breast cancer treatment. And we reserve time to ask questions and discussions following her presentation. We have few introduction and housekeeping slides, and I turn it over to Laura.
Good afternoon, everyone. So this educational activity is a project of the TexLa Telehealth Resource Center, a federally funded program with FMRI Rural and Community Health at TTUHSC, as well as Well Ahead Louisiana, and that is with generous support from Health Resources and Services Administration, or HRSA. And CME credit is available for participants of the live webinar here today. A link to take the survey to get those credits will be provided at the end of the presentation, as well as emailed to all attendees. And then these are just a couple helpful tips for our webinar and to ensure you can receive CME credit if so desired. So please make sure everyone is muted, and any questions you may have, please type those into the chat during the presentation. And now I'll let Dr. George introduce our speaker.
Dr. Carla Lee is a Texas native who completed medical school at Texas Tech University Health Science Center after transferring from Boston University School of Medicine. Dr. Danelli stayed in Lubbock after the completion of a medical school to pursue her surgical career. And following the completion of general surgery residency at Texas Tech University, she completed additional training and fellowship in breast surgical oncology in Pittsburgh, Pennsylvania. Dr. Danelli joined as a faculty of the Department of Surgery at Texas Tech in 2022, and her areas of expertise are nipple-sparing mastectomies and nerve preservation mastectomies for breast neurotization. I hope I'm pronouncing it right. Dr. Danelli's specific areas of interest involves obesity and breast cancer, breast sensation after cancer care in high-risk populations. Thank you so much for being here today and with us today. Dr. Danelli, we hand it over to you.
Thank you so much. Thank you for the opportunity to speak about something that is very dear to me, obviously my favorite topic, and it's October, so what better time to talk about breast cancer than October? So I'm going to go ahead and share my slides. Let me know if I have two screens, so one might be presenter mode and one might be my actual slides, so let me know if I need to make adjustments. How are we at? Is that the right screen?
Yes, looks great.
Okay, perfect. Well, thank you so much for the introduction, and again, for having me in this forum to present about breast cancer and some of the applications of telehealth that I've implemented in my practice and that I've seen are a great feature in bridging those gaps that our patients have, especially in this community. A lot of our patients travel from very large distances, so telehealth has really been an amazing asset in providing for those patients. So why breast cancer matters and why should we even care about it? Why do we have a dedicated Breast Cancer Awareness Month? There are so many other cancers. Well, next to non-melanoma skin cancers, breast cancer is actually the most common and prevalent cancer in the United States. This year alone, over 300,000 cases are estimated to be diagnosed. And that translates, and it's not just females, it's also male breast cancers. Obviously, it's a much smaller subset of people who will be diagnosed with male breast cancer, but it's still a large number of patients, American patients, who will be affected by this disease. And not only just diagnosed, but a lot of them will have consequences of it and eventually result in death. And if we do the math, that death of breast cancer statistics turns out to be about 25,000 cases per month of new diagnoses and about 823 per day new diagnoses. So those are very big numbers, and that's why we need to raise awareness. We need to keep doing our part and increase research so we can better treat it and have better survivals. But also in Texas alone, we have an estimated over 20,000 new cases for this year. That equates to over 1,800 new cases per month and about 61 cases per day. That is in Texas alone. So yes, it is a very, very prevalent disease and we should pay attention to it. The breast cancer journey is composed of many different pieces. Every patient's a little bit different. Not everyone follows the same path, and everyone might take some different routes, but our end goal is to cure everyone and get them to that survival stage, from the diagnosis to the surveillance or survival stage. And even though everyone's path looks a little bit different, it's mostly composed of these different pieces. And every piece to me is an opportunity for intervention, an opportunity for telehealth per se to interfere and bridge gaps or disparities that occur at every single step. So when we are talking about imaging, there's obviously disparities in getting access to imaging. So bridging those gaps. Delivery of a diagnosis after you have a biopsy. So every step of this pathway is an opportunity for us to bring telehealth into play. And before we keep talking about telehealth, just for clarification purposes, let me go over some definitions or terminology that and how I will use that terminology for this presentation. So the FCC says telemedicine is the use of telecommunications or telecommunication technologies to support the delivery of all kinds of medical and diagnostics for treatment-related services, which is usually entailed by the doctor. Telehealth, on the other hand, is very similar to telemedicine, but it also includes a wide variety of remote healthcare services beyond what the doctor-patient relationship is. This often involves the services provided by nurses, pharmacists, social workers, nurse navigators, other people other than physicians. And telecare refers to technology that allows consumers to stay safe and independent in the comfort of their own homes. The AMA, however, defines telehealth and telemedicine a little bit different. It tells us that it is the exchange of medical information from one side to another through an electronic medium. And CMC defines telehealth as a two-way, real-time interactive communication between a patient, physician, or a practitioner from a distant side other than where the practitioner is residing. For the purposes of this discussion, all these terms are going to be used interchanged. Anything that allows for remote care, I will be referring to as telemedicine. So we can probably define those in the Q&A at the end of the discussion. So what are some of the telemedicine technologies that can help with breast cancer? Where we have a variety of avenues. There's video conferencing, there's mobile apps, there's remote monitoring, there's even the concept of teleradiology, chatbot, secure messaging. There is a multitude of avenues in which we can stay in touch with our patients without having that face-to-face time or interaction. What are some of the benefits of telemedicine that we see in breast cancer care? And not just breast cancer care, this applies to all cancer care. We can see reduced delays in treatment because we don't have to rely on patients coming back to see us to have a conversation. Let's say patients have a biopsy and they have the result that turns out to be a cancer. We do not have to wait for those patients to take time away from their already busy schedules, about to embark a very busy journey with cancer care. We can bridge those gaps and find it flexible times to schedule to deliver that information, deliver or address any health concerns that they might have. So it makes access to our ongoing care a lot easier so we don't experience those delays. It also offers a huge financial benefit for patients, which is probably the most attractive aspect of telehealth. According to this recently, well, not recent anymore as it's last year, but it's still recent since it's the same year, but we're about to change. We did find that the average cost savings for breast cancer patients utilizing telehealth was $147 to $186 per visit. If you remember that little wheel and all those pieces of aspects of care that patients go through when they're diagnosed with breast cancer, we're looking at breast cancer patients visiting the cancer center or their health provider at least once a week, at least for that initial 6 months of their care, if not more often. So that is a significant financial relief if we're able to minimize those face-to-face visits for patients, especially because cancer care is also very expensive. So specifically in telemedicine, these are some of the things that I want to talk to you about and give a little bit more background and understanding and how telehealth can be applied specifically for breast cancer care. So breast cancer screening, obviously, prior to even a diagnosis, if we screen in early detection, that is the most cost conscientious thing we can do and the best thing we can do for patients. So screening should be readily available, readily promoted. But because of remote mammography, we are able to even extend care and screening to remote locations where it might not be possible. This all came about and was made possible because in the late 70s and 80s, we started that shift from digital, from actual printed films to digital imaging. That was the start that paved the way for this to be positive. In 1991, we also had some experimental telehealth with teleradiology. The US military experimented with this in an operation called Operation Desert Storm, in which radiology images that were taken in the Gulf were transmitted via satellite link to medical centers in the US, usually like Walter Reed and other military bases. And this allowed for fast diagnosis. It was very cost efficient and it gave them logistical advantage. So we saw the implementation with very positive feedback as early as in 1991. Throughout the 1990s, we also experienced a revolution in communications and specifically telecommunications with the rapid growth of internet and all the advances in technology that we experienced through the 90s. Everything got revolutionized to the point where to what we are right now. In 1994, that was the very first time that ACR, which stands for the American College of Radiology, adopted guidelines to define what teleradiology was going to be, and so we could have standardized care across the board. It gave a clear definition of what it is. It defined quality of image. So if you think about pixelation and things that we were experimenting in the 1990s, just remember what our phone pictures used to look like 10 years ago. So the quality became an issue where if you had access to the actual machines that were retrieving those images, they were a lot better quality than when you were trying to transfer them. So that had to be defined to minimize those quality aspects of it. Also, equipment needed to be standardized since this entailed that the radiologist was not going to be in the same area as the equipment. We need to make sure that everyone followed these guidelines, and also guidelines for the transmission and security of patient storage. Another thing, while this not exactly is telemedicine, it is more remote medicine, but it opens the avenue for telehealth to be implemented, is mobile mammography. Mobile mammography is the utilization, they're usually vans that have equipment that can do screening mammograms or breast cancer screening in a remote location other than hospitals or imaging centers. They are very useful to areas that have limited access to imaging facilities like rural locations, and it bridges the community as it brings those resources to them as opposed to bringing them out of their own community. Patients really like these kind of services because they can have their screening, their care in the comfort of their own community. There are some drawbacks specifically for this, which is why they're not super popular, but something that maybe in the future we can improve and make it a lot more available. It is limited by the locations that you visit. It is because it's a mobile unit, you are affected by environmental factors. If you have a storm, you might not be able to reliably get there. If you're trying to get image acquisition during an earthquake or something that's providing movement, then your image is not going to be the same. Space is also an issue. These are not little vans. The equipment needed to obtain mammograms is pretty large. So these are very large vans to accommodate for that space. And there's a lot of maintenance that happens. So this equipment, like I mentioned earlier, there is standardization of the equipment, meaning that it is going to stay up to date. There's maintenance ongoing. Because it's very sensitive equipment, anytime we move it around, it will require for that to be in service a little bit more often, and that's costly. So there are a lot of costs that come with mobile mammography, but it does answer the question of access to care. Again, I briefly mentioned about remote results and care coordination. So when patients typically have a mammogram, they don't come back for their results. They usually get a phone call or their PCPs get notified directly. It minimizes the amount of time that patients have to keep going back. That's why we never speak with radiologists, because they've been very smart about implementing telehealth in the sense that if there's something abnormal, if patients are going to need additional imaging, they are either contacted directly to come back and those additional testings are done for them, or their PCPs get notified so they can create a treatment plan. On top of breast screening implementations that telehealth can help with, for breast cancer itself, there's a lot of applications, and specifically in areas like Lubbock, Texas, where we are the center to treat for a lot of conditions, especially oncologic conditions. So it provides access to specialties that are not readily available in other locations. When we talk about Lubbock and the surrounding area, this, I don't know if you can see the picture here with the pink diagram, that encircles about almost 80 counties in Texas, but in area, it's almost a third of the land in Texas. And those pink dots that I have inside the dotted lines is the number of breast surgical oncologists. That is a very, very small number of specialist providers like myself. And we're on the verge of missing one or losing one at the end of this year. So that's going to leave us with 3. Whereas if we look at areas like Houston, obviously they're a lot more populated. I did a brief research on how many breast trained specialists they have. And as we all know, there's a lot of different cancer centers available in Houston, like MD Anderson, Methodist, Baylor. There were a total of 11 breast dedicated, which means they only address breast cancer care in Houston. And those top 3 that I mentioned, MD Anderson, Methodist, and Baylor. So MD Anderson has on staff 26 dedicated breast surgeons, Methodist 11, and Baylor 3. So when we look at the disparity in access to a specialist, we realize how important it is for us to bridge those disparities that are given by geographic location. And again, to treat breast cancer, it's not just the surgical oncologists. We also have medical oncologists, radiation oncology. There's a lot of mental health services that are required to help patients and their families cope with these cancer diagnoses. After their care, there's also physical therapy. They need to recover, and our goal is to get them back to what their pre-cancer state was. It also allows us to get more family involvement. So this study that I'm displaying here looked at 584 women that had a median follow-up of 10.3 years. And what they noted was, what they noted was that these families that were more involved in the care of their loved ones, their young women with breast cancer, had an associated overall lower risk of death. We don't fully understand why. That's just something that we observed from this study. But if you think about it, that is going through a cancer diagnosis is not something that you want to do alone, and not something that you can feasibly do by yourself. You need the support of your loved ones or your support system. So with telehealth, we bridge that gap by allowing them to be part of your visits, by allowing them to be part of your treatment. It also engages patients for increased participation. Patients that have a cancer diagnosis, we know they do better if they get in touch with other people who have been diagnosed with similar cancers, who have gone through similar experiences. They will be able to provide resources that us as healthcare providers, without ever going through that diagnosis, we might not understand all the minutia or the social limitations that this cancer has, but bridging those with telehealth and communication for patients, they can expand their group, their support groups and survival group to a nationwide thing. So it really brings them together, and it helps them go through these diagnoses a lot easier. Telehealth also helps us with treatment decision when it comes for cancer care. It's not just a one-man show. Like I mentioned, there's so many different players and so many different specialists involved in the care of a single breast cancer patient. And something that we routinely do is multidisciplinary team consultations, either that being in the same physical location or remotely. With telehealth, we can now access providers that we might not have in our own towns. If we have maybe a surgeon and the medical oncologist is somewhere else, we can bridge those gaps, discuss patient care, and review the best treatment plan for them. It also gives patients the opportunity of getting second opinions. While second opinions, at any time someone mentions that, you think, oh, this is the patient not trusting what the initial diagnosis was. No, it's not just for patients. We as physicians also get second opinions from other places. Let's say we are dealing with a very rare cancer that it's not seen in our area very often. We have the ability of us ourselves, even as providers, consult with people who have seen this or have more experience in this specific cancer. Patients can also request a second opinion to better suit their needs or their goals of care without having to travel, without having to absorb that financial burden of finding someone else that treats for breast cancer, especially in areas like this one where, like I showed, it's a very limited number of providers that can offer those services for them. Education. While you go through cancer care in general, there's a lot of education that happens from the beginning. You get a lot of education with your biopsy, what that disease process is, what that means. And a lot of the times, traditionally, for patients to get this information, it requires them to keep coming back for appointments, even if they're non-clinical appointments, just so they can learn, just so they can get more power and education and resources for them to better understand the journey they're about to start. But with telehealth, we're able to minimize those trips, and even provide wider ranges of education with specialists and providers from different areas and locations to better suit the needs of patients. Every cancer patient is different. Even among breast cancer care, there are very different paths or very different specific minutiae that apply to patients depending on their biology. So we can better tailor the education that they receive, which can be done at the comfort of their home. Data sharing, again, because of geographically where we are here in Lubbock, a lot of our patients receive their diagnosis or get their diagnosis and workup elsewhere, and then they travel to Lubbock to get treatment. So with the support of telecommunications, we are able to transfer their imaging, their workup, what their physicians are thinking in terms of their PCPs, what their general health, what medications are they taking, without having to go back and forth or having your patient show up like, oh, what medications are you taking? Well, I'm not sure. I just saw my PCP. We don't have to rely on just the patient memory or the patient bringing their records. We can directly transfer from one side to the other. And the same thing applies once they're done with their cancer care. We can reliably share their treatment plan, their overall treatment goals back to their PCP so they can continue their care in the comfort of their communities. And I mentioned earlier, when we're treating patients with cancer, our goal is to get them from a diagnosis to treatment to eventually survivorship and just surveillance. And what exactly is survivorship? Survivorship is a very broad definition and a broad term that encompasses the comprehensive care and the management of patients after they've completed their primary breast cancer treatment. And that includes a myriad of components, including monitoring for recurrence, monitoring and management of the early, late, and long-term effects of their treatment, secondary cancers, their rehabilitation process, the psychosocial aspect, not just for them, but also for their family members, lifestyle. This is a great time for us to start addressing lifestyle modifications, either from nutrition, exercise, smoking cessation, things that increase your risk of developing other cancers or other medical conditions per se. It is an excellent avenue for us to keep giving education. What avenues, what do we need to keep looking forward after we're done with that initial stage of their treatment? We can also help with advanced care planning. So all in all, it's a very broad term that goes on for almost the entire lifetime of patients. Because once you've had a cancer diagnosis, you will be a survivor until we expire. Remote monitoring and management, especially applied when in the survivorship care of phase of breast cancer. So this study here was published in 2022, in which telemedicine was shown to very positively affect the physical and mental health, sleep outcomes, quality of life, and overall body image of patients. It also showed that some promise to not only the patients, but also the providers. For us as providers, there's a lot of emotional burnout, emotional fatigue when we're treating cancer patients, because not everyone responds the way we want them to. It is very emotionally exhausting knowing my patient lives an hour away. I don't know if they're going to make it to their next chemo. I don't know if they're going to be able to make it to their next appointment. So by providing that relief for providers, it also showed that providers themselves were benefiting from the use of telehealth and not just patients. Again, we all, even though there's a lot of positives that came from this review, it also recognized and emphasized some of the limitations, which is the adoption of telemedicine, its training, its cost, the workflow is different. We all tend to have some hesitation and reluctancy to change. And also currently the reimbursement plan, it was not very cost effective for providers. But ultimately, the overall message of this review was how it can positively affect patient care, families, providers, and bridge all those missing pieces in the breast cancer care. It also helps us with connections to resources. Again, when we're in smaller towns that we might not have all the resources that big centers like MD Anderson have, the use of telecommunication can bring those resources remotely for us. It can also provide an avenue for ongoing education, healthcare promotion. I mentioned we have the capability of, after their initial treatment plan, trying to address those healthy lifestyles. Therapy, we can identify patients that might qualify for therapy via, let's say, for lymphedema, for example. Lymphedema is a very chronic problem in breast cancer care. It is the chronic swelling of extremities. Whenever we remove lymph nodes in the axilla, we disrupt the normal flow of drainage in that affected extremity that can a potential sequela is that chronic swelling. And a physical exam on telehealth, it's a visual diagnosis. We can identify that. And instead of having patients come to us for treatment or management, we can give them the resources to get that done at the comfort of their own communities and their own towns. It gives an avenue for support. Again, mental health support is a great example of how telehealth helps in breast cancer care. Mental health providers are very limited, but with the advantage of not having to be in the same location to receive those services, we have been able to provide better care for our cancer patients. And then there's also clinical trials and research that telehealth has been able to overall make better and bring those extra resources for patients who would have otherwise not have the option of participating if you lived in a small community. It broadens their research potential. It allows researchers to recruit participants for a much wider geographic location rather than only those that are very close to the institution. With this, it allows patients to enroll in trials that are, again, not offered locally. And with this, it gives the patients flexibility to look for trials that are the best suited for their needs and circumstances, not just the trials that are offered in their community. It also helps us diversify the population that is enrolled in clinical trials. This has been a topic of concern for clinical trials for a very long time, as we know that there's an underrepresentation of certain populations in clinical trials that might not necessarily translate in the clinical application of our results to those minority groups. And just for everyone to know, the typical demographic of patients enrolled in clinical trials tends to be white, older individuals from a higher socioeconomic status and from urban areas. That urban areas, because the resources are close to them, it doesn't really represent our rural locations or the demographics that make up those rural locations. It also helps us reduce the dropout rate. So anytime we're involved in a clinical trial, it's not just, well, active treatment is getting administered. We need to follow up what that treatment did 5, 10, 15, 20 years down the line. So if you're not in that same area, geographic location where your trial was being conducted, the follow-up period was very challenging and we couldn't get good information of what was happening down the line. So again, with telecommunications, we are able to have things like remote monitoring. The participants eliminate the need for in-person visits. You are more eager to participate and stay engaged. We reduce that frequent travels, we make it easy, we make it flexible. And again, it is a lot more likely for people to stay enrolled, stay engaged if we make it easy and as comfortable as the comfort of your own home. Also, again, support is something that will come at every single stage of breast cancer care, from diagnosis to our survival, and even through clinical trials. We know that patients are able to get more resources for different variety of support systems, like financial support. There's a wide spectrum of industry-sponsored clinical trials that patients might find advantageous, even if they're not offered in their own communities. Again, psychosocial support, educational support. It also allows for patients to report real time any concerns that they have with their clinical trial, either treatment or down the line. And it not only limits it to that previous face-to-face time encounters. It also gives us a flexibility in the design of trials, so we can better prepare those trials and encompass more patients. It allows participants and the study designs to broaden their spectrum. With telehealth platforms can be tailored to suit the needs of the patients and the trial specifications. By decentralizing the clinical trials, patients are able to be treated closer to home, closer to their own locations. It also allows for data collection in vivo. There's wearable devices that can provide real-time information back to that central component of the trial, like vital signs. So again, all of these bottom down to the fact that it increases patient engagement. It increases our ability to get data. We get better data reporting if we allow patients to report signs, symptoms, concerns all the time, not just during their visits. But as amazing as telehealth is, there are some limitations that I'm very hopeful that over time we will be able to bridge those limitations and make telehealth even more readily available. There are limitations with the technology access or literacy of our patients. Not all patients have access to the necessary technology needed to participate. For the majority of our telehealth visits, we do require at least something similar to a smartphone, anything that allows for audio and visual communication in real time with your provider. And that might not be the case for everyone. And the impact of that is that there's a digital divide that can further exacerbate those health disparities if we are making telehealth available. Those with more access to technological equipment will be more readily engaged in telehealth, whereas we further push away those patients who are already facing some access to care. There's also some limitations with the communication and clinical exams that we perform. So some aspects of communication are not just verbal, they're not just visual. There's a lot of body language that can be missed with these type of communications or engaging virtual appointments. Specifically for breast cancer, physical examination is a very key component of breast cancer care and diagnoses. And even staging, we rely on physical exam very much so to know how to better stage patients, what the next treatment plan is going to be. So that is something that we have not figured out how to bridge that lack of physical examination other than visual with breast cancer care. We are not able to provide remote biopsies. That does require an one-on-one inpatient small intervention. Even though small, it's still not something that we have been able to answer with telehealth. And a lot of that, the ramifications of this is, as providers, we lose that ability to gauge their emotions, their understanding, or how comfortable they feel. It is very easy to have a smile on a Zoom meeting and just keep nodding and say, okay, yeah, all of this sounds great. Whereas if you're in person, you get a lot more. Are they fidgeting? Do they look uneasy? We get to better understand how they're feeling, how they're processing the information that we're giving them. And again, like I mentioned, there's a lot of these components that we have not been able to eliminate that in-person visit in order to get a very comprehensive care. Again, a big mention is privacy and security concerns. Telehealth platforms have to be secure enough to make patients and providers feel confident that every exchange of protected health information is going to be securely stored and it's not going to end in a place where it's not intended. And even after that, cyber security is a big thing, something that even the best of places, we just experienced. Look at Las Vegas casinos last month. They have a lot of resources for cybersecurity, and they're still targets for information bridges. So this is something that, as providers, yes, when we're engaging in telecommunications or telehealth, we're very good at controlling our own environment, but we have no way of controlling what's going on the other end of the screen, where patients are, who is next to the patients, what is the their surroundings. Is someone who's not supposed to be listening to this conversation around them? We cannot control that. So there's still some privacy violation concerns when it comes to telehealth. And then lastly, regulatory and reimbursement issues. We are not there yet to make it, at least on my end, that probably has been my biggest limitation to keep providing telehealth support to my patients, is our policies have not adopted appropriate funding and reimbursement. There are a lot of fees that are lost on the health provider aspect. It is very cost efficient for patients, but in order for us to keep providing care, there needs to be some reimbursement to allow for those services to keep going. So that coverage, hopefully things keep getting better and it gets recognized as not just something that we do as an emergency, but the norm. There's equity concerns, like I mentioned early on with technology access. We further divide those people that might already be at increased risk of not having access to care. But we also have people who may not necessarily speak English. We might not necessarily be adept to use technology, like elderly patients. We try to educate patients on how to use technology, but it's very intuitive. Our kids grew up with cell phones. They probably were able to use an iPad before they were able to speak. So it is something that's very intuitive that might not necessarily be translatable to our elderly population, which breast cancer tends to affect the most. And even though they live 5 hours away, they might not have access to a telehealth visit with me because they are not able to understand how to work the system, how to use an iPad, how to use that iPhone. And for them, an in-person visit might be the way to go. But hopefully, as these technologies have now been around for longer and that we're all more familiarized with them, and that they're now second nature, over time we'll notice that these limitations tend to be less and less. And again, probably the biggest limitation is patient and provider acceptance. We are all creatures of habit. We don't like change. If we didn't start having telehealth as a big part of our practice, we tend to be very reluctant. I was very lucky to have met with Dr. Santos very early on in my practice, and we had the opportunity to talk about telehealth. He actually gave a telehealth lecture at the very first breast symposium I attended, and that's sparked the conversation for us to say, okay, well, that's not something that has been done here in Lubbock before. It's me being brand new and barely getting my practice going. It allowed me to start it from the get-go and made it very easy for me to adopt and go back and forth from in-person to telehealth visits. And I very quickly realized that a lot of my patients are traveling 5 hours. A lot of my patients do not have the money to travel those 5 hours every time I need to give them a result. I need to give them their biopsy result, their mammogram result. So I'm able to reserve those trips for things that are absolutely needed. For our survivorship, what we've been doing is alternating an in-person and telehealth visit every 6 months. So that liberates those patients from those very far distance travels. So I feel very blessed that I was able to adopt it so early on, but that's not necessarily the case for all providers. And with that, I just want to end with a patient story. This is a patient of mine, one of my very first patients, and probably the first patient I ever utilized telehealth with. BD, she's an 83-year-old female. She was diagnosed with a triple negative breast cancer back in October of last year. So she's now on her 1-year anniversary of her diagnosis. So we're very excited about that. And while she didn't necessarily live 5 hours away, she still lived in La Mesa, which is about an hour, a little bit more than an hour away. And again, she's 83 years old. She does not drive by herself. She relies on someone else to drive her. She lives with her daughter. Her daughter is the caregiver for her, both financially and otherwise, and she's a baby store owner. And prior to her diagnosis, she was extremely active, very independent, other than driving, and she assisted daughter in the store, so both of them kept it alive. Both of them relied on that store financially. After her diagnosis, they did realize that traveling was going to be a big financial burden for them, because anytime she needed to come, both of them were out of the store. No one was working the store. But because we implemented telehealth, that liberated them a little bit. After their initial visit with me, we proceeded with our routine tumor board, where all the providers that take care of breast cancer patients, we get together once a week, we review all the new diagnoses, and this was her mammogram. When she was first diagnosed, she was diagnosed with multi-centric breast cancer, which means there are two different regions of the breast tumor growing within that breast. So here I have those two arrows showing what looks like two different masses, one big one and on the corner a smaller one. While we were all presenting, this image looked a little different in the sense that that corner smaller mass not necessarily looks like a breast tumor. It has a very similar morphology to a lymph node. So because we were all together at the same time discussing it, everyone said like, oh yeah, you know what? That does look like a lymph node. Even though the biopsy that was sent to pathology said it was a second mass, we were able to review it. We got pathology slides, and indeed, we confirmed that it was a lymphoid tissue in that area. So that, in terms of staging and treatment options, it made a huge impact for the patient. Instead of committing her to 100% getting chemotherapy first, we were able to optimize her goals of care by knowing that, okay, well, yes, we do know there's two different areas with breast cancer, but that second one is not a second tumor. It's just that primary tumor that has traveled to a lymph node. So patient went on, because again, also because of the electronic medical record. This patient's 83. She's not, even though she's very independent and otherwise doing well, she was not the healthiest. She had heart issues, history of seizure disorders. So we relied very heavily on her PCP to help us manage her other comorbidities while she was going through her breast cancer care. And that was a seamless process for her because of the electronic medical record, that anytime she came to her visit, the PCP was immediately updated and she had access to all of the information regarding her breast cancer care. She then went on to have surgery first, and she opted to have the whole breast removed along with all the lymph nodes. And here's just a depiction of what that surgery looked like for her. She did fabulous. Even though she's 83 years old, she recovered extremely, extremely well, extremely fast. Everything was uncomplicated from a surgical standpoint. But as we all know, breast cancer, or cancer in general, is not just treated by surgery. There's other things that are involved. So a lot of discussions went on back and forth on whether or not we needed to do more, specifically for her own goals. Also, during this perioperative period, we always offer any patient with a new diagnosis of breast cancer, while it's not an obligation, it is an option to undergo genetic testing. So we do know that about 20% of breast cancers have a genetic predisposition. She opted to undergo genetic testing, and to our surprise, even though she was not diagnosed with something that predisposed her to breast cancer, she did have a genetic mutation that predisposed her to colon cancer, which in turn, what it means for her and her family is that her kids have a 50-50 chance of developing, having that genetic mutation that increased their chances of colon cancer. So again, with the use of telehealth, we were able to counsel her kids, give them the information of what that genetic mutation was, what the risk of colon cancer were, what the probability of them having that genetic mutation were. And the majority of them opted to have genetic testing following that conversation. Again, like I said, she had her surgery. Surgery alone is never the only thing that we offer for breast cancer treatment, but because of her age, her other comorbidities, and the fact that her goal of care was to continue living as active as possible and return to her pre-cancer state as quickly as possible, there was a joint decision for her to forego chemotherapy or other treatments. So we do know that especially triple negative breast cancer, which is what this patient had, even when we do everything, patients have surgery, patients have chemotherapy, patients have radiation, the recurrence rate is really high. It's about 40%, even when we do everything as indicated. In her case, we opted to forego some of those additional treatments, accepting that the likelihood of recurrence would be very high. And what we did for her, we increased her surveillance. We knew that, okay, well, the chances that you're going to get another cancer, hopefully locally, are going to be very high. And our goal is to identify it as soon as that recurrence happens. And we were able to do telehealth again, where we saw the patient, either myself or the medical oncologist, every 3 months, by alternating an in-person visit. Again, we do need those physical exams, and telehealth visit. And within those first 7 months, the patient gave us a phone call saying, there is something not looking right in my skin, right above my scar. That immediately prompted more questions like, okay, do we need to do additional workup? She was able to upload pictures through the comfort of her home of what this skin irregularity looked, that I was able to review and say immediately, yes, we need to come back. I need to do a biopsy of this skin. Because again, there's no more glandular tissue. The entire breast tissue is gone, but the skin where that tumor used to be was still there. And indeed, it was found that she had a local recurrence. Again, we did not delay care because she was able to send that picture as soon as she found something. We didn't wait those 3 months. We didn't wait for her next follow-up appointment. She had her biopsy, and as soon as we got those results, we started the next phase of her treatment. So for that second stage of her, we call it a recurrence, she underwent a local re-excision. Because it's a recurrence, she qualified for different chemotherapies that she didn't qualify the first time around, which are oral, which means she does not have to keep coming back to get infusions and get lab checks. She can keep taking a pill at home. And then we also treated her recurrence with radiation because we knew it happened at the skin. So we were a little bit more aggressive. But again, she went on for those 7 months without having any extra visits, any affected mobility, any side effects of these treatments, which allowed her and gave her the flexibility of traveling, visiting with family members. She took a trip to Tennessee. She took another one to North Carolina, where she had relatives that she had not seen in over 20 years. So she was so thankful for those extra 7 months that she had without those side effects, without those limitations that radiation or chemotherapy can bring with them. Also, anytime, like I had mentioned earlier, anytime we remove lymph nodes from someone's armpit or axilla, there's a chance of developing lymphedema, especially if we remove them all. And that risk can be as high as 50%. And in her case, it was almost a 50%, if not higher, because of her age, the fact that she had had previous surgeries to her shoulders, 2 to be exact. She got radiation, she got all the lymph nodes removed. And we've been able to create a treatment plan for her, an evaluation plan that does not require her to visit every 3 months or every so often. It's a visual exam. That's a visual diagnosis that once we identify that she's developing, or hopefully not, we can get her the resources or start treatments for that lymphedema. So again, like I mentioned, even though she didn't have the most perfect oncologic outcome, she did have a recurrence, especially within that year. She's extremely happy, and we were able to provide care to her that was in line with her goals of care and goals in life. She did not want to just ignore the cancer, knowing that it would probably take over and she would end up dying from that cancer if we left it untreated. But even though we didn't do all the treatments that are typically indicated for her specific type of cancer, this allowed her the flexibility to travel. She was still able to help her daughter and minimize the times that daughter and patient had to be away from the store. It minimized the financial burden on them because of the care. Also, her entire family was able to participate during those visits. She has her kids that do not necessarily live in La Mesa, they live in neighboring towns. Whenever we have telehealth visits, they're able to commute to Lamesa, which is a lot closer to them than coming to Lubbock. And they all get to ask questions and learn about what this breast cancer diagnosis meant for them. That's how we were able to engage them in genetic testing. So this was an excellent way of getting not just the patient, but everyone who's a support system for this patient engaged. We also got our PCP involved in this. Again, she was not a very easy and straightforward patient. We did require to monitor her heart a little bit closer, make dose adjustments for her seizure medication as it has some changes with the chemotherapy or the surgeries or all the other treatments that she was getting. So patient did not suffer any side effects from that regard. Her regular health was not neglected because we were able to keep her PCP engaged at every step of her breast cancer care. And again, the patient was able to freely communicate any concerns. And because of that, we did not delay any care for her. She noticed something. It was not even a real lump. It was, the skin looked a little different, was able to send us a picture, all while staying at home. And we were able to get her to the treatment that she needed right away. So to me, this patient story is very dear to my heart because, again, it's probably the very first patient that I offered telehealth, one of the first cancer patients I treated. And I see it as a very successful story. Even if the cancer itself was not perfect, the patient is extremely happy and the delivery of her care was never compromised. So in conclusion, by overcoming the barriers, telehealth has the potential to enhance the access to care. It improves convenience, it contributes to better health and outcomes for breast cancer patients, but I would say all cancers and, in reality, all patients. That's all I have for today, and I'll welcome any questions now.
All right, I know we did have one question in the chat. Thank you everyone for being with us today. And this was wonderful, Dr. Danelli. Thank you so much for joining us. I really appreciate personally the case story because I think that kind of ties everything together in a way that we can all relate to. Because all of us have probably been patients at one time or another. So one of the questions that we had in the chat was, if you could please tell us what your vision of the role of telehealth in breast cancer care in West Texas would be in the future.
My goal is for everyone involved in breast cancer treatment adopts what I'm doing. Currently, our cancer center, I'm probably the only one. Our geneticist is also, we are the only two providers that are implementing telehealth. So for all those oncology appointments, those radiation oncology appointments, we're still making the patients come in. So that's why my goal is to emphasize stories like this and have it that my providers also get on board with the implementation of these resources.
Thank you, Dr. Danelli, for this excellent presentation. And I really appreciate the way you took us through this breast cancer journey. I had one question before we end this discussion is, for example, I have a patient who has the oncologist in, say, Permian Basin, and then I have the surgeon over here, which is you. And I'm maybe, there are certain sent out pathologies like mammoprint, AI, Oncotype DX, and things like that. It's in multiple places. So how do you coordinate the care in such a situation?
Yeah, and that's actually something that's very common in our practice. Just because they're my surgical patients, that doesn't necessarily mean that their oncologic care or their radiation oncology happens here. Especially if they live in a community where they have those resources, we obviously want to ensure that they stay closer to home. They do not need to travel these distances for care of all their oncology care. If they have someone close to them, we want them to do that. We encourage that. So what we do is, again, a very direct transfer of records from one facility to another. And that's something that I have been working on growing, is my relationship and my networking of more community type physicians that provide oncology care. Because again, I absolutely do not want my patients that are in Roswell, New Mexico, that come for me because I'm the closest breast surgical oncologist, to keep coming here for all those hours of driving to get radiation oncology when I know for a fact that they have radiation oncology resources and medical oncology resources. So it is very easy and convenient for patients to do that. And all it takes is for us to be on board and be willing to go that extra mile of transferring of records. Again, it is not available here. It does take one extra step, but I think that extra step or that extra mile of pushing for record transfer is the best treatment for the patient.
Wonderful. We would like to present Dr. Danelli with the prestigious TexLa TRC Challenge coin for the wonderful webinar today. And this being the Breast Cancer Month, I really think your discussion today has been very impactful, and we look forward. And we are very fortunate from the West Texas to have you as our breast cancer surgeon. So we thank you for everything that you're doing for us.
Yes, thank you so
much
much
for having me.